multiple sclerosis, principles of physiotherapy. The successful treatment of the neurological defects found in multiple sclerosis requires a combination of the skills developed in other specialized areas, particularly from the treatment of stroke, head injury, spinal injury, and cerebral palsy. The physiotherapist may be involved from the earliest signs to the terminal stages of the disease, and she therefore needs to be acquainted with all the appropriate techniques required to treat any of the many possible signs and symptoms. At each stage, specific techniques will be required to treat the neurological deficit and to allow any potential a chance to reveal itself. Every attempt must be made to facilitate normal development, normal movement or coordination which may have been lost during an exacerbation or period of immobility. Prompt intervention will reduce to a minimum the deficit and avoid the effects of forgetting due to lack of experience. General principles of assessment and treatment are described in the early chapters of this book, and readers are advised to refer to the specialized section for help with specific problems. Here, general advice for the planning of treatment will be given, and for convenience, special advice and points for emphasis will be indicated as though the course of the disease could be divided into 4 stages, although in practice, one will merge with another. Aims of physiotherapy: to re-educate and strengthen all available voluntary control, to re-educate and maintain normal postural mechanisms, to maintain full range of motion of all joints and soft tissues, and to teach the patient and or his relatives suitable stretching procedures to prevent contractures, to incorporate treatment techniques into the way of life by relating them to suitable daily activities, thus providing a means of maintaining any improvement, to offer advice about sensible use of energy, to prevent the use of abnormal movement which is inefficient and tiring in itself and may inhibit function, to stimulate all sensory and perceptual experiences and maintain the experience of normal movement throughout the course of the disease, not only to exploit potential but to enable the patient to feel safer and move more freely when the assistance of relatives or helpers is required in later stages. General preventive measures: no two patients are alike in either their circumstances or their symptoms, thus, no two treatments can be the same. However, whatever approach is adopted, there are certain problems seen in most patients with disability which must be anticipated and prevented. Plantar flexed feet: these can be prevented by avoiding the use of a total pattern of extension by weight bearing, by attention to the posture of the feet when sitting, and by daily standing if walking is no longer functional. A predominant pattern of extension and adduction in the lower extremities. This can be inhibited by training correct weight bearing through a mobile knee, by attention to adequate flexion at the hip joint when sitting, and by the use of tailor sitting to stretch the adductors. Knee flexion contracture: this can be prevented if the hamstrings are stretched by touching the toes in long sitting while keeping both knees extended. Hip flexion contractures: these can be prevented by ensuring good hip extension when walking or standing. Daily prone lying should be encouraged. Flexed thoracic spine: this can be avoided by active dorsal extension in sitting and when prone, stretching by supine lying over a pillow or in sitting with hand support behind. Flexion and internal rotation at the shoulders: this can be contracted by training balance reactions and by self-assisted full range shoulder elevation. Fixed head positions: these may be avoided by training adequate balance and postural reactions and preventing the use of abnormal movement patterns. Special emphasis needed at different stages. Early advice: initially the patient may complain of poor balance on the stairs, difficulty with fine finger movements or heaviness of one leg, and eye symptoms or some sensory disturbance may be present. If the patient is referred to a physiotherapist at this stage, however minor the deficit appears to be, a thorough assessment of movement in all positions will enable suitable advice to be given about any potential lack of symmetry in posture, movement, or balance which is observed. If appropriate emphasis can be given to certain activities in daily life which would stimulate postural and balance responses, example going up and down stairs one foot after the other and standing from sitting without using the hands for balance, lifting one leg across the other when putting on shoes and socks, emphasis of dorsal extension during dressing or when reaching for objects. If suitable activities can be introduced as a part of the daily routine, it saves devoting time to special exercises. However, if more specific emphasis is required, additional work in standing or on a tilt board or large ball can easily be practiced at home. The benefit of resting in a position of side lying rather than supine can be explained. Also, that the patient must learn to lie in a prone position either over a pillow, foam wedge, or suitable cushion, perhaps while reading or watching television or even while sleeping. The usual occupation and pastimes should be continued. During the assessment, work and leisure activities may be discussed with a view to conservation of energy. This is similar to the consideration which is given to joint preservation with arthritis sufferers. For the MS sufferer, the danger of doing too much seems less than the danger of doing too little, but slight adjustments made in the organization of the daily routine may avoid undue fatigue and conserve energy for more enjoyable pursuits. The patient should be advised to keep fit and healthy and encouraged to pursue some form of active exercise. Some neurologists prescribe the REST exercise program developed by Richie Russell. The program is designed to influence the circulation around the spinal cord and brainstem and consists of 2 or 3 rest periods of 10 to 20 minutes each day, preceded by a regime of stressful mat exercises such as press-ups and weightlifting carried out until the patient is dyspneic and the heart rate increased. Other neurologists prefer to encourage participation in sport such as tennis, badminton, and swimming or riding, which provides valuable recreation as well as keeping the patient active. Any abnormal patterns of movement observed during this activity should be corrected because if continued, they will reinforce the abnormal at the expense of the normal. After initial and intensive re-education and instruction during the early stage, patients may find it helpful to attend follow-up sessions every 2 or 3 months to evaluate the program and to discuss any other problems. Regular outpatient physiotherapy should not be necessary nor encouraged if adequate adaptation has been made to daily activities. Slightly more marked signs but walking unaided. If the signs and symptoms increase, reassessment is necessary and adjustments made to their management. It is helpful to involve relatives and, if necessary, visit both home and work to make further suggestions about sensible use of energy and ways of overcoming particular problems. The physiotherapist should be ready to ask the help of other members of the team, example social worker, nurse, occupational and speech therapist, and dietitian. The same principles of management are continued, but special attention may be needed in the following. Diet. If necessary, advice should be sought as an increase of only 1 kg can affect mobility in a person with even minimal increased tone in the legs. Paradoxically, when ataxia is a feature, energy output is increased, and this, in combination with tiredness and labored feeding, could result in a gradual reduction in weight. As the signs become more marked, concern about the future increases and social psychological problems may arise. Frequently, some of the fear and depressions can be relieved if the patient and family are given a fuller understanding of the symptoms or practical guidance to overcome the physical or financial problems connected with employment, mobility, or domestic arrangements. Occasionally, skilled counseling may be helpful to overcome specific marital, family, or sexual difficulties. If some of the psychological stress can be alleviated, energy can be channeled more constructively towards enjoyment of life in spite of the handicap. If the function of the bladder or bowel is affected, the patient should understand that correct management of them could influence the amount of tone throughout the body. The bladder may be hypertonic or hypotonic, and increased irritability or retention or any infection will increase tone generally, which is in turn could affect mobility. Bowel function should be managed to avoid constipation, at this will cause as this will cause increased tone and may also affect bladder function. Particular attention will be required to overcome undesirable habits and to teach the specific stretching activities already mentioned to prevent any adaptive shortening. Whatever type of abnormal tone is present, there will usually be reduced rotation in the trunk in an attempt to maintain stability when walking. Therefore, activities to encourage facilitation of this must be incorporated into treatment sessions and into home or work activities. For example, a suitable self-activity could be side-sitting to inhibit extensive thrust, rolling both knees together from one side to the other, and if the arms are clasped above the head, this will emphasize much needed dorsal extension. When ataxia is present, the activity may be adapted during treatment so that approximation can be given through the arms in a lifting pattern. In addition, always turning on to the side before sitting on the edge of the bed to get up will facilitate rotation and head and trunk righting reactions. Use of walking aids. Great care must be taken when an aid for walking becomes necessary, and suitable activities which will counteract any detrimental effects should be encouraged. These effects may not be immediately apparent. Where possible, aids should be given during a refresher course so that proper instruction and evaluation may be carried out and arrangements made for a further follow-up. Typical points to watch would be alteration in posture due to learning on the stick or crutches, marked reduction in balance reactions of head and trunk through using the hands for balance resulting in increased difficulty with other functional activities in lying and sitting, possible alterations in distribution of tone throughout the body requiring extra care to maintain all isolated movement available. In a wheelchair for part of the time, the chair should not be used full time until absolutely necessary, and every effort must be taken made to keep ambulant if at all possible. However, it may be advisable to use a wheelchair for long distances in order to save time and to avoid unnecessary fatigue. This is a very dangerous period in management, and many complications are directly related to insufficient guidance at this time. The inevitable reduction in amount of activity and increased use of the sitting posture usually led to an alteration in patterns of spacity and movement, which will need specific treatment if potential problems are to be avoided. The prescription of the wheelchair requires full consultation between the user, his relatives, and all members of the team. There are many guides to assist the necessary decision, but a few points will be mentioned as a simple basic mistakes as frequently made with rather serious consequences. If the chair is not correctly measured, it can cause or increase abnormal postures, especially if it is too wide. The height of the foot plates is particularly important. They should be able to be adjusted to achieve a right angle at the hips and knees. Some elevating leg rests do not allow this and should be avoided. Heel straps, which are fixed to the foot plate, are frequently ordered. Unless altered, they hold the forefoot in an unsupported position, and this leads to increased flexion of toes. The slightest tightness of toe or plantar flexors increases spasticity and could prevent walking or later the vital use of standing for transfers and maintenance. A strap behind the legs is more practical. Some reclining backrests will not raise sufficiently to allow a right angle at the hips, a fact which may alter the management of tone and posture in the trunk and legs. Wheelchair management should be very carefully taught. It is as important for the MS sufferer to receive the same detailed preparation and instruction in the use of wheelchair which would be given to a person with traumatic paraplegia. This means meticulous attention to symmetry of posture with even weight distribution on both buttocks. The patient should be warned not to maintain asymmetrical positions for long periods. For example, always leaning on the same arm could lead to a scoliosis and affect the tone in the trunk and legs. The degree of flexion at the hip will influence both the position of the head and trunk and the pattern of spacity in the leg. Too much extension at the hip can increase extensor thrust in the leg. Hip retractions on one side can produce a pattern of flexion, adduction, and medial rotation with corresponding decrease in functional ability. The automatic use of the wheelchair arms should be avoided unless necessary for safety. This will stimulate a more active sitting posture, which will help to retain balance mechanisms. Sitting in a suitable ordinary chair makes a change from the wheelchair. The period when there is increased use of the sitting position requires close supervision, not only to ensure adequate management of the tendency of hypotonus to change from extension to flexion, but also to prevent contractures. The patient must walk each day, and if extra support is required in the way of gaiters, splints, bracing, a suitable walking aid, or parallel bars, these should be readily available. Any interruption in the routine may mean not only losing the skill forever, but a risk of introducing a vicious circle of complications. Extra care with stretching of muscle groups which tend to shorten is vital. A pause to give an extra stretch each time a transfer is executed will help to maintain the length of the calf muscles and the hip flexors. The prone position and tailor sitting will maintain range at the hip, but specific stretching and of hamstrings in long sitting is required. It is usually necessary to check a full shoulder elevation, especially if ataxia is present, because this movement is performed so rarely in daily life. There may be considerable changes during this period. Probably even part-time work will no longer be practical, and alternative pursuits must be found to continue an interesting and stimulating life, and to continue a responsible role within the family and social circle. Guidance may also be needed on various aspects to retain personal independence. This may include advice about suitable clothing and footwear, as well as other aids which would enable the person to remain independent for as long as possible. Full-time use of a wheelchair. Once walking is no longer feasible even for maintenance, additional provision must be made for standing. The physiological benefits of standing include reduction of spasticity, maintenance of length of hip and knee extent flexors and calf muscles, more efficient drainage of the kidneys, and possible benefits to counteract osteoporosis. Support for the knees in standing could include gaiters, plaster of Paris, or polythene back slabs, or long leg bracing. If needed, suitable apparatus must be supplied to assist standing at home. In residential care or hospital, a tilt table may be used with the patient prone or supine, but care is required to obtain equal weight bearing through both legs. It is of more benefit if standing can be an active and not just a passive experience. Correction of symmetry and posture and activities to encourage balance can be practiced while in the upright position. Additional help may be needed to improve independence at home. Modifications to the bed or bathroom may retain independent turning and transfers or make it easier for helpers to assist. If the standing transfer has been maintained, it is usually possible for relatives to manage a pivot transfer even when the disease is advanced. If necessary, the patient may have to ask relatives to assist with positioning, stretching, and pressure relief. If he is no longer able to correct the sitting posture himself, extra care is needed to check that there is equal weight distribution and good alignment of the trunk and limbs. This is particularly important on some air-filled cushions, which frequently overcome problems of and balance and posture of the head and trunk, which affect feeding and speech or asymmetry in the lower limbs, which could be the start of vicious circle of complications. Management of spasticity. Spasticity and its management has been fully discussed in Chapter 7, but it needs to be reiterated that managing spasticity in multiple sclerosis is of the utmost importance. The following points need to be continually remembered. Diligent attention to educating the need for avoidance of positions and activities which increase tone or reinforce abnormal movement patterns. Daily walking or standing for weight bearing, which has an inhibiting effect on hypertonus. Constipation, bladder infections, pressure sores must be avoided. Regular stretching of all potentially tight structures, especially at danger times, example illness or the transition to a wheelchair. Contractures must be prevented at all costs. Action must be taken as soon as there is any difficulty in obtaining full range by either increasing the amount of treatment or using some other adjunct. Prolonged application of ice, either locally or for total immersion, can be used effectively for a temporary reduction of hypertonus. The inhibitory effect of drugs such as baclofen and diazepam is sometimes helpful, but close monitoring is required as they may reduce arousal and active ability. Use of splinting needs careful consideration as without extra treatment it may actually increase the problem. Removable splints are usually ineffective because the corrected position is not maintained and they are difficult to reapply. However, at danger time, splinting in the form of an all-round plaster of Paris cylinder for the leg or below knee weight-bearing plaster can sometimes be considered to inhibit spasticity. If contractures do occur, application of serial plasters can be used to correct the shortening. Intrathecal injections of phenol may be useful but require knowledge of the neurological mechanisms involved as well as an understanding of the implication of any imbalance in a movement disorder. If the ataxia is also present, the possible reduction in stability should be considered. Surgery may be required either to divide or to lengthen tendons, example hamstring or tendon Achilles, or in the form of a partial or total neurectomy, example obturator. However, unless the original cause of the problem is eliminated or different management is introduced, the difficulty is likely to recur. Management of ataxia. Ataxia and its management has been discussed in Chapter 7, but as with spasticity, ataxia requires understanding and continual treatment. The following points need to be remembered. Attention to ensuring adequate experience of movement can easily be overlooked because of the voluntary control present, which makes the lack of use less obvious to the therapist. Many patients voluntarily restrict movement of the head and trunk to gain more stability, and extra emphasis should be given to the stimulation of balance and writing reactions during treatment. Instability and difficulty in performing activities against gravity often leads to the use of abnormal patterns of movement or reflex attitudes in an attempt to increase tone and achieve stability. This may appear to be an acceptable short-term answer, but later on it may contribute to reduced functional ability. Example, pressing the head into extension and rotation against the back of the chair can affect tone in the limbs and reduce demand for already poor head control. Always folding the arms or pushing one arm into extension and medial rotation may assist sitting balance but will prevent use of the arms for more skilled functions and predispose to contracture. A person with poor coordination tends to push against any available surface to achieve stability. Therefore, any straps, aids, or props used to assist certain functional activities, if permanently fixed, may actually increase abnormal movement and could eventually prevent the original function they were aiding. Some approaches, example those developed by Dr. Frenkel and Professor Pito, have emphasized use of cortical control in learning and training motor ability. The principle of using repetition of activities with variation in speed, rhythm, and range, reinforced by speech, hearing, and vision is valuable and can be superimposed on all functional activities. Additional management, respiration, breathing exercises should be incorporated into the program at all stages. If the muscles involved in respiration are affected, the patient and relatives can be shown suitable positions for postural drainage and how to assist coughing to clear secretions. In advanced cases, use of suction may remove secretions more effectively if coughing is tiring. Feeding, it is particularly important to be aware of the effect of position and posture on a patient's ability to feed independently. Training balance reactions, head control, eye-hand coordination could help to retain the basic motor skills required to bring the food to the mouth. Techniques to normalize tone, increase sensation, and facilitate voluntary control within the mouth help to maintain patterns of chewing and swallowing necessary for efficient feeding. Whenever possible, the patient must be encouraged to feed himself, and adaptations to cutlery, non-slip mats, and thermoplates can be helpful. In many instances, a liquid diet is given when what is really required is advice about suitable position and instruction in facilitation of chewing and swallowing. With the right help, it should be responsible for a normal diet to be enjoyed. Solid food will help to retain the ability to chew and stimulate lip closure and tongue and cheek movements. Maintaining good oral feeding patterns will also help to maintain speech patterns. Communication and mobility, a variety of systems to assist with the use of telephone, radio typewriter, and other communication aids can be supplied to allow more independence. Various forms of motorized transport are available for those who cannot manage a hand-driven chair. Bladder and bowel function. Incontinence can cause much embarrassment, but problems arising from such distressing complications must not be accepted as an automatic outcome of MS. Adequate management is possible and dignity can be maintained. Much help can be gained by reference to the careful management according to bladder and bowel function and spinal injury units. The initial responsibility for accurate diagnosis causing the incontinence belongs to the doctor, but the therapist may be involved in establishing a suitable training regime. The therapist must be aware of the need to avoid infection of the bladder or retention of urine, as this can damage the kidneys and also have a marked effect on spacity. Constipation is a frequent problem with MS. It is aggravated by reduced mobility and has a marked effect on spacity. It can be helped by allotting a regular time of day for bowel movement, a larger fluid intake, and a high residue diet. If this is insufficient, regular aperients and suppositories every 2 or 3 days are used to train a convenient and regular routine. The therapist can help the patient and his family to accept that effective management is possible in most instances and is of vital importance both medically and socially. Prevention of pressure sores. Pressure sores can be prevented if attention is given to stressing special positioning to inhibit spasticity and to importance of relieving pressure in bed and in wheelchair. The patient need no longer fear that pressure sores are inevitable.